I just want to introduce Professor Laura Rosella. She is an associate professor and Canada Research Chair in Population Health Analytics, and is also one of the most amazing people at U of T. I don't know how she does all that she does, but her work has really been important for the advancement of health systems in Canada, and she's been a part of so many different conversations in communities like the Vector Institute, ICES, and of course here at U of T. So it's really a pleasure to introduce Laura Rosella for our final talk of this term. And with that, I will turn it over to you, Laura, and I look forward to hearing what you have to say. Thanks again for taking the time.
Well, thank you, Michael, for that really nice introduction. And thank you all for coming. I know it's the last kind of wind down week and everybody is unbelievably exhausted. And so I just really appreciate you all coming and hearing what I have to say today, and hopefully starting a discussion of something that I think needs a lot more input from lots of different perspectives, which is what I think this speaker series does really well. So I'm going to just quickly tell you a little bit about how I'm going to structure the talk. Feel free to put in questions in the chat. I won't look, but I will look at the end, and I will save enough time for us to have a bit of discussion. I'll keep an eye on the clock. So there are basically three sections to the talk today. First, I'm going to talk about performance management for health systems, and recognizing that some of you and some of the names I recognize are really familiar with this concept, but some of you may not be. And so I'm just going to briefly talk about why it's important, why it's useful, some of its limitations as well. Then I move into how we can start thinking about incorporating resilience into performance management. If we accept that it's a useful tool, although with some limitations, why would incorporating the concept of resilience be useful, and how might we do it? And then I'll end on some recommendations moving forward. Throughout, I'm going to draw on some examples from the work I do, and obviously some examples from COVID, because it's top of mind and very relevant for this topic. Before I start, though, I am going to give you 3 points of context to hopefully help you understand the frame at which I'm coming to this issue, but also some context about the health system. I know many of you work in the health system and with the health system deeply. Some of you interact with the health system quite a bit, and everyone's observing it and all its guts, if you will, in the COVID pandemic. And there are some things that aren't maybe obvious to the front that I think are important to mention. First, on the context about me and the lens at which I am coming to this. So I run something called the Population Health Analytics Lab with an amazing group of research staff and trainees. And basically what we do is figure out how to use data in an action-oriented way. So we focus on assessing risk on multiple dimensions, as those are critical for population health, and I'll talk about that and how that fits with resilience. We focus a lot on distributions in the population, and you'll see some of that as we talk about this concept of resilience and why it's important. And the last and more important is sort of the action-oriented piece, which is how we inform strategies to better optimize resources, interventions with needs. And this is where I think some of all of the work that we do and the people that come to these seminars might be interested in, and how we use data to do that. So the other context I want to emphasize, and again, I think this is something that wasn't obvious to people that aren't working directly with the health system, is that there is quite a bit of a divide between the public health and the healthcare system. So the healthcare system, which is what many people are familiar with, it's where you get care when you need it, when you're sick, maybe thinking for preventive services, screening, etc. And then there's the public health system, and it's different in every province, it's different in every country, and it's different, you know, even locally. In Ontario, just as an example, they are quite different systems. And when I mean different systems, they're funded differently, they operate under different legislative authorities. And ideally, I think everybody would assume that these systems work together, but there are some barriers that prevent that. And the reason why I'm bringing up this contextual point, I want you to keep this in the back of your mind, I'm going to keep coming back to it, is that when we talk about performance management and we talk about performance management in the context of a system, we're not talking about one health system, we're talking about two health systems, and that creates challenges. Then you bring in the concept of resilience that really embraces and intimately touches both public health and healthcare aspects. It becomes quite a bit more complicated. So we're going to come back to this throughout. And I want to mention that there's some structural barriers that are preventing these two systems from operating optimally together. And you can think of public health as the provision of collective services, which focuses on broader determinants of health and population focus. That's where I mostly work. And healthcare is the provision of individual services. But as I mentioned before, they're funded differently. They have different governing structures. It's a really nice article describing these challenges by Breton and all that I put here if you're interested. At last bit of context, there is a transformation happening in most health systems around the world, various types of transformation. But the most important one for us to keep in mind today is this transformation towards population health management. Again, if you think of healthcare systems as the provision of individual services, there's been an orientation towards redesigning health systems to focus on populations versus individuals and all of the aspects of populations and communities. And that's actually a big challenge. It's not the way these systems were set up decades ago, and it's not the way the data flows. It's not the way that people are paid in the system. So it's actually quite a big undertaking. And if you're familiar with the changes happening in Ontario, you may have heard of Ontario health teams. We're just about to transition before COVID started, so we haven't probably heard as much about them lately. That was the idea, transitioning from individual providers and hospitals to actually authorities that take care of a population and manage all aspects of that population. Okay, so those are contextual points. Keep them in mind. I am going to come back to them. So let's now talk about what performance management is in health systems. So performance management is this idea that you regularly collect and report data to track a specific result and see whether those results are achieved. One of the key aspects of performance management is that it's done on a routine basis. It's usually tied to some decision or action that will follow. And again, going with the sort of idea that we have different health systems, there's a performance management indicators for healthcare, and then there are some for public health, although I will say this is a much more common concept in healthcare. And I'll give you some examples of what this looks like. But before I do, I want to just talk about the evolution of this concept. I was really lucky this year, actually was supposed to physically visit Sant'Anna University in Pisa, but obviously that didn't happen, to visit with some scholars there who are actually, internationally renowned experts in performance management in healthcare, Lana and colleagues. And they do most of the health system performance management in Europe and set standards for it. And so we wrote this article about the evolution of performance management over time. And you can see here that when it started, performance management as a concept, it really was a budgetary control issue. Make sure that we were spending our money wisely when it came to healthcare. We weren't wasting resources. And over time, this concept evolved to the idea that we want multidimensional performance. Eventually, the recognition that we must listen to the patient's voice, slowly moving to the population perspective, looking at performance variation, and then finally thinking through societal value. And as we've emerged over time with these different concepts and evolved in sort of our thinking of why performance management is useful, the concept of value has also emerged. So it's not just a fiscal piece that we were really focused on in the early 80s, but now we're thinking of value in terms of population health, in terms of equity, triple aim. And these are the aspects which are now being embraced in terms of a performance management framework. And the actual terms, resilience and sustainability, are actually showing up in the performance management literature just now. So we really are at the cusp of thinking how we can use this idea of managing and setting standards and incorporating this concept of resilience into that framework. So here are some examples of performance management indicators, and it's not an exhaustive list. It's just meant to give you an idea of what we mean when we do performance management. For healthcare systems, you have entire organizations. We have several in this country, provincially and nationally, devoted to generating these indicators on a regular basis. Things like 30-day surgical readmission rates, time to first surgical or specialist appointment from a diagnosis, having a regular family doctor, et cetera. And on the public health side, again, performance management indicators do exist, although they're not often talked about in the exact same way. And there's fewer of them, and they're not necessarily adopted federally or equally across different provinces. But they could be things like immunization rates or alcohol-related hospitalization, smoking rates, premature deaths, which I'll talk about a little later. So the key piece I want you to take away here, if you've never looked at a performance indicator, is that there's directionality here. So it's not just what's happening. It's not just interesting information that can give us hypotheses about what we can do. There's actually a direction, more is better or less is better depending on it. And maybe there's standards or benchmarks, which is why they're often thought of in a quality sort of framework. So hopefully you have a sense of what performance management is in healthcare and in health systems. And I'll now move to talking about performance management as it relates to resilience. So health system resilience is one of those concepts that's, somewhat seemingly simple concept with not a simple definition. And in fact, we are still struggling to define what this means for health. There must be about 10 scoping reviews, published in the last year or 2 years, trying to figure out what health resilience means, health system resilience means, community resilience. I'll talk about all of these things. It means we're at a point where we think there's this thing that's important, but we actually don't know quite how to define it in the concept for health. We know it's important because these major events happen, like SARS or Ebola or climate disasters or COVID, or even the global financial crisis, which had significant health implications. And we know we have to do something about it, but we haven't sort of embraced it as a fundamental core concept just yet. I think everyone recognizes it's important. COVID's definitely accelerated our thinking in that if we want to monitor how health systems work, we want to monitor if they're achieving their intended outcomes, resilience must be a critical aspect. And Krukenall and Lancet really put out a definition. This is again in response to Ebola, but you think, it can apply to multiple situations. And it's the idea that the health system, including the actors, institutions, and populations, which is why I like this definition, really reflects everyone that's involved, can prepare, can respond, can maintain core function, and also change if needed. And there are several aspects to resilience that are worth drawing out a bit more, because if we're going to say that we're going to track resilience as a core indicator that we need in our health system and actually measure progress and measure how we're doing on it in a proactive way, then we have to understand all the elements of it and actually how complicated it indeed is. So this is, again, a framing of it that we used in our article, but it's also shown up in various ways, described this way using various terms. So the first is structural. And the structural aspects of resilience really talk about being prepared. So you can have a health system, a public health system, or a healthcare system that's really, really prepared. And you can actually measure preparedness in different ways. And we'll talk about how you could actually possibly measure this. But that in and of itself is not enough. There needs to be flexibility in the system or it'll break, as the engineers in the audience will know. And the first type of flexibility we talk about is adaptive. So that's the idea that you can actually keep up what you're trying to do with whatever resources you have. You can reallocate, you can move resources around, you can keep up the services in response even though a shock is happening. So with COVID, perhaps we're talking about being able to keep hospitals going and ICU capacity going. And that's not just about having beds and ventilators and rooms to isolate COVID patients, but it's about having staff and nurses. And actual critical care nurses is a very specific specialty. And so people need to be trained specifically. They need to have the resources to work in a critical care unit. So perhaps you have to train staff and move staff around the system to be able to meet the demands of the ICU. And the last one is transformative, which is the idea of making health system reforms or actual changes in response to that shock. So a good example, again, in the context of COVID, I'm going to use COVID examples a lot because I know it's something that everyone can relate to at the moment, might be the transformation that's happened in virtual care. We've been trying to do virtual care at scale in this country for decades. Maybe 2 decades, maybe I'm exaggerating, but at least a decade. And all of a sudden we had to adapt. And that's a transformation. Virtual care is now with us and will stay with us even beyond the shock of COVID. So also this year, Thomas and all from the European Observatory on Health Systems and Policies put out a policy paper on health system resilience. And it's a useful paper because it talks about what's needed and again presents this sort of framework of all the aspects of resilience. And the reason why I'm showing it is because if we think about measuring health system resilience, we must think of all these stages. Again, you can write this in different ways and there's more complicated stages, but this is sort of a useful framing to organize all the dimensions of resilience that are possible. And from a measurement perspective, again, we'll talk about this preparedness aspect. So generally speaking, better performing healthcare systems are better prepared in that they have the resources, they have plans. They also have resources dedicated for shocks, perhaps resources that they need to deploy, given that they're going to be depleted in certain areas, for example. Then there's the actual shock itself and alert. And this is where, and I would say just in this green part here, a lot of health systems do not too bad here. Although again, we don't measure this systematically, we don't benchmark it, but you can see how, some systems can do okay on preparedness. As we move across, things start unraveling a bit. So on the shock onset and alert, it's about being aware that it's happened, being ready, and then having the data and actions to follow. And I'd be curious to what everybody thinks about how we did in response to COVID in our health system. So certainly there are surveillance systems in place, but did we have the data maturity for the data to flow quickly enough on the right? Were we measuring the right things? Was it telling us the right things to inform action? And so these are systems that need to be set up and in place. If you start building them in the context of the emergency, it becomes very difficult. You're always trying to build the system, put the train tracks down as you go, and it poses a number of challenges, especially being timely in the context of an emergency that's quickly moving. So there's absorbing the shock and then there's doing something about it. And so we're in a situation right now where we've absorbed the shock, but have we put the policies in place to actually act accordingly? So if we think of, let's say, long-term care, for example, there was tragic impact on long-term care for COVID in the first wave in our province and in many jurisdictions around the world. And quickly policies were implemented. Were they enough? Could more have been done? Certainly that's true. But did we have the information early on to be able to make the actions that follow in order to minimize and manage that shock? And again, love to hear your thoughts on how you think that this is happening with COVID. And then finally and critically, we have to learn from what's happening. You should never come out of a shock or a disaster or any event without going back to things being the same. Something must advance. We certainly weaknesses in the system are revealed, and I'm sure everybody has an opinion on what weaknesses were revealed with all health systems around the world and social systems and all kinds of systems through COVID. It revealed the cracks in the system. So that mindset of active learning and evaluation, and also the legacy effects that can happen as a result of the shock is really important. And if you do any evaluation work or active learning work, which I know some of you do, you have to be resourced to be able to do this. And you have to set up the information needs and gathering as soon as possible to be able to make sure that we're better prepared for the next one. I haven't yet talked about community resilience. We had an amazing talk by Blake Poland and community partners on community resilience. And I want to make sure that, so I won't go into it in tons of detail, just given the limits of time. But when it comes to responding to any shocks, to any system, actually, I'm learning through the speaker series, the importance of community is critical. And what that means is that the better off our communities are in terms of them thriving on multiple dimensions, the better off they are able to adapt and have that flexibility and respond to threats. And again, this cuts across all the concepts we've been talking in health, in food systems, in supply chains, a really critical element, and is, I'll say, missing from most performance management concepts, and actually missing from the way we measure health in general. So it's something I'll bring up a little later in one of the projects I'm involved in. But you can see all the aspects involved. The other idea is that it's constant. It's not, to have a thriving community, it's not something that you can just come in, set up, fix at one point in time. It has to be something that's continual, that addresses structural issues, and has that constant desire to have a flourishing, thriving community. And so it's about social connectedness and resilience and meeting those at risk. It involves health system, but also involves a bunch of other organization. And when we think about it with a resilience framework, it's this idea that you attain a positive outcome at the individual, at the family, and the community level despite adversity. So we'll come back to this. Actually, we'll see it in real time in COVID. So these are the, I forgot to mention at the beginning, some of you know, but some of you may not know that I was at Public Health Ontario during H1N1. I worked on a number of response studies and looking at the differential impact of H1N1, and have been working on COVID in a variety of roles and advisory tables. And one of the aspects that I'm focused on in COVID is looking at the differential impact of who's been impacted across different dimensions in the community. And so this is rolling average of COVID cases by neighborhood socioeconomic status. Everybody knows the story here, and it doesn't take a lot of analysis to see that this is an area-based measure. There's lots of analyses, but those that generally living in more deprived areas or who are more deprived themselves are experiencing a disproportionate burden of COVID-19. And this has been pretty much since the beginning, except in the first few weeks where it was mostly travel related. It was actually disproportionately among those with higher incomes, but that changed very quickly. So if we think about this with a lens of resilience, the first thing we might want to consider is, well, obviously certain groups are, we weren't prepared for COVID in many ways, but more so, certain groups were disproportionately affected and continue to be so. And you might look at this and say, well, oh, that's a surprise. We should do something about it, which might be, I don't think many people are thinking that, but when you're seeing these data come in, which actually we didn't quite have data on these stratifiers early on, you might be thinking that. But in fact, there's lots of reasons that we know that we should have expected this. So pretty much every epidemic since the beginning of time, literally since the beginning of epidemiology, the cholera outbreak of the 1800s, when we first started using epidemiologic methods to identify causes of disease to have an impact, we knew that there were structural factors that made certain groups disproportionately affected. Lots of people who learn the history of epidemiology, learn about John Snow and the pump and isolating the cases and finding out that, they were on Broad Street, so they took off the handle of the pump and cholera went down and we discovered cholera. So I'm, telling the story very quickly. But actually, if you read some of John Snow's original writing and other scientists that were working on this in the day, they talk about the predisposing factors of those that got sick. They were in poor living conditions in this area of London, in crowded spaces, with inadequate diet. They were overworked, horrendous labor conditions, poor ventilation, crowding, poverty, class, occupation. Those were the drivers of who was affected with cholera in 1800s. And we've known this since the beginning, although it was not the focus and even not part of the story when you hear about it. 1918. This is a graphic that I just find so interesting from a statistician who literally went door to door. Well, he didn't do it, but there was a group of individuals that went door to door asking people, whether they were well-to-do or poor or very poor, these very coarse categorizations. So again, 1918, no surprise. We know that certain groups are disproportionately affected by 1918 pandemic. And then a bit more recently, we have scientists and infectious disease doctors such as Dr. Farmer, who's also a medical anthropologist, asking the question, so why is it that certain infectious diseases come to affect some bodies but not others? And really emphasizing that the root causes of these disproportionate burdens are things like agricultural change and racism and colonial histories and trade. So in fact, it should be no surprise that socioeconomic gradient that I showed you earlier, the surprise is why were we not prepared for it? And if we go in with a resilience mindset, could that help us be a little more prepared and actually make sure that we've done the things that we should have done in advance to make sure that those that are most vulnerable are actually protected? There was actually a meeting on, this is influenza. So there's been a lot of preparedness work in the context of influenza, with the thinking that influenza would be the cause of major pandemics. And since then, it's been evolved. But in 2006, there was a meeting held in known as the Bellagio meeting on social justice and influenza. And they actually came up with a checklist for pandemic influenza preparedness and response plans. And in this document, they start by saying, although it's generally recognized that the next pandemic could have far-reaching consequences in terms of morbidity and mortality, comparatively little attention has been paid on the ways in which the pandemic could disproportionately and negatively impact socioeconomically disadvantaged groups. And they had a whole meeting about it and came up with this checklist. And this checklist is really about, it's not perfect. I think there's, pros and cons to the way they framed it here, but at least starting to think about how you could be prepared and move from preparedness to actually the onset and the alert planning. So basically measuring and monitoring with care who's affected and keeping track of where there's disproportionality in terms of burden in the population, and engaging disadvantaged groups and their representatives in the planning process. I think that, again, that's something that many have called for during COVID, around the world. This is not an Ontario problem. This is not a Canada problem, US problem. Around the world, I think that this could have been done better. And identify and address the special needs of those groups and the context and recommendations to prepare. So again, with the resilience mindset, and perhaps if we were measuring this and monitoring this in a performance managed framework, maybe some of these would have been in place. Of course, not the only thing that will drive change, but certainly could help. And so once you have those that information, what could you do if we think through stage 3? So things like occupational health and safety measures, which took a very long time to come into place in many health settings. The big one, appropriate paid sick leaves and benefits, which is definitely contributed to much of the occupational challenges we're seeing, disproportionate occupations being affected, biases in care, testing strategies being targeted, listening and building trust with communities, and starting to plan now for the next one, because there will be a next one. And just like from the 1800s to now, I hope I'm not showing you a very similar graph, but unless we change something with the way we measure and monitor and plan, it will be the same. And then lastly, the learning and recovery. And with COVID, I just wanted to mention the idea that there are legacy effects. So there's the direct impact of COVID, and then there's the secondary, tertiary effects, such as the impact of unemployment, the income loss, delayed medical care for those that need it, trauma for all those groups that have been disproportionately affected, maybe loss of educational opportunities because of school closing, and these all have downstream effects. Okay, so hopefully through the context of COVID, I've given you an example of how resilience mindset, maybe we weren't prepared for it, and how thinking about it and thinking through it could have helped, although, you know, recognizing that there's lots of complicated factors for what we're seeing and what we're seeing and how COVID's playing out. So how could we, if we accept that resilience is an important concept and we accept that performance management serves some function, then how can we actually measure resilience? And I want to just touch on some of the challenges with measuring resilience. As I said in the beginning, we are really at the cusp of embracing this idea that resilience is something that's critical, it needs to be measured, and it needs to be built and thought of in advance. So first, we have limited data and varying definitions, both in healthcare and in public health. And the challenge here, because the resilience concept is so broad and not agreed on, we're still at the stage where we don't know what we're measuring. And when we do figure out what we think we want to measure, we realize, oh, that's actually really hard, because I'm not just counting readmissions, I'm not just measuring wait times. I actually need to think of some very complicated topics. I need to think about community engagement. I need to measure preparedness, which is a difficult concept to measure. And the other thing, remember I mentioned that to have successful performance management indicators, they have to be directional. Well, directionality may be difficult to define. So let's take communication as an example. During an emergency, a public health emergency or other crises, communication is key. Everybody can agree on clear communication. When the postmortems are done on all these events, the idea that communication played a critical role always bubbles up to the top in either the success or the failure of the response. And clear communication on what people have to do, what's happening, transparency. But what's the directionality here? So you could have someone communicating every day. Maybe you have a press conference every day. But the effectiveness of that communication might be very difficult to measure. They might be communicating and reaching some of the population, but totally missing subgroups of the population. I think these are all things that we can imagine are a challenge with how we actually measure and need a lot of thought. And you can see how they can go well and not well. So communicating, just having that communication channel is definitely not enough. It actually can be counterproductive. So how do we start measuring some of these concepts? And this, again, a framework on health system resilience. This is, again, more on the healthcare side. If we look at all the dimensions here, you know, many of these, again, we'd be challenged to think of what the direction is and how we direction. So we're really on the cusp of refining some of these measures. On the public health side, I would argue our biggest challenge is that we just simply do not capture data routinely on the things that matter most. And this is not a fault of anybody that's setting up, you know, surveillance systems. It's just, you know, really difficult to measure things that we know affect populations most. So especially societal, structural factors, community and relationships, but it's not impossible. So this is where the next wave of performance management, especially as it relates to public health and population health, really is going, trying to grasp and measure in a meaningful way these really complicated, complex topics that's going to take us into data streams we've never used before, but we know will have a huge impact on populations. So the second challenge is indeed this idea of capturing population and community perspectives. And I'm going to go through this a little bit quickly because of time. But essentially, we know that the determinants of population health are structural and cut across populations. And again, these things are often missing when you look at value of health gains to individuals versus society. And sometimes they can even create conflict because you can have individuals that can benefit from specific interventions tremendously. And the incentive to actually work on some of the more challenging structural factors can be hard to argue for when you're seeing individual health gains. So this is the struggle of having a population health perspective in any measurement paradigm, the idea that you have to look at distributions, how gains are made in some groups and not others, and how that wide variation actually is one of the biggest challenges that we have to manage in terms of how the health system responds and functions. I was going to talk about a project that we did where we actually had a table of health system decision makers and came up with measures of health system sustainability and equity. But I think I will skip it in the context of the time we have left, but I'm happy to talk about it after. My main takeaway from talking to you about this study was how difficult it is to reflect variation in the populations. It's the trends, it's the relative difference, it's the pace of declines in some groups versus others. These are concepts that are really difficult from a performance management framework because we like to say things are going up and down, and then you layer on, but they're going up and down for some subgroups at different rates. And this is what creates a huge challenge in terms of how we absorb that information and what we do about it. And the last thing I'll talk about with measurement, and then I'm wrapping up on recommendations, is just, I'm alluding to it, but I haven't said it explicitly, is that we are getting out of health, right? So health systems embrace the concept of performance management. They use it. It can be used to drive quality. But now we're saying that actually it's all these other domains outside of health that really influence how a population will respond to shocks. And we do not have the data structures or the maturity to deal with all that yet. It's not impossible, but it's a big challenge, which slowly over time we're overcoming with linkages and multisectoral collaboration. And one example is a project I'm involved with that I hope I can come back and talk to you about. We've just started. It was a bit delayed because of COVID, which is a partnership with the City of Toronto, who are thinking about how we can use data in innovative ways to inform community safety and well-being. And this is community safety and well-being plan is actually legislated for every municipality in every region in Ontario. They must have a community safety well-being plan. They must have indicators, and they must have a framework for evaluation. And so we're trying to work together to think about how we can integrate some of these concepts we've talked about today. And of course, resilience is at the core of that. And we're grappling with a lot of things, like how much we focus on communities or individuals, how much we use objective and subjective measures. At this point, we're trying to get a representation across. But this kind of perspective, again, relates to performance management, because if we're really performing well, we should actually be capturing all these domains. And in fact, we have to start going into territories that are unfamiliar to maybe some people that strictly worked in the health setting, like environmental, economic, human, and social areas. So this is just to make it a bit more concrete, brainstorm some of the resilience indicators that we could possibly start thinking of. They need refinement, and they need a lot of debate in terms of its conceptual stability, as well as the ability to actually measure these things. But again, let's think back to COVID. So maybe an indicator would have been understanding how well we can provide income supplements in a rapid way in the face of a severe economic shock. And so we did pretty well with CERB, but it was not perfect, and there's some huge challenges, especially now. And it's critical. It's critical to health and many other aspects of resilience. So that's something that, again, could be thought of in a performance management framework. The engagement of community. So I, again, love to hear people's thoughts on this, but the idea that the community has a strong voice, we heard this very well in Blake's session about how critical it is to have community directly engaged and a strong voice. And that's something that you can indeed measure. You can set up in advance, you can foster, nurture, put resources on. And once you start measuring it, we can legitimize this type of activity in times when there's not a huge shock to the system, making sure that we're investing it up front. That's true for community participation in decision-making, social connections in community. Those recommendations that were in that 2006 report, for example, I haven't seen them adopted in very many preparedness plans at all. It's been, 15 years. I don't, and we're seeing the impacts of them now. We weren't really ready for that. The idea of running simulations, which is critical and very possible, and of course some mechanism in governance. And this is just what I was saying, these are very simple ideas I'm just throwing out here for the purpose of the talk, but there's some critical things to think about. So the conceptual development of these indicators, the major infrastructure investment that's needed, especially for modernized data flows for many of these things that we're talking about. And I haven't yet said who does this performance, which is, I know, probably on some of your minds. With health system performance measurement, there's often a third-party organization responsible for this, and the idea is that there's quality and oversight. If we bring in resilience concepts and population health and communities, is that model still appropriate? I think it's something we have to ask ourselves. Okay, so let's end off with some recommendations and final thoughts, and that should leave us with enough time for questions. So hopefully by this point, you have a good sense of what performance management is in health systems, if you didn't before, why we do it, and also have a good understanding of what resilience is and what it means for health systems and why it might be important to put these pieces together. So if we were going to incorporate resilience in the performance management system, and we are, I think health systems, performance management systems around the world are definitely embracing the idea that they have to incorporate resilience. I think knowing how to is still a big question mark. This is the point where we're at in the history of performance management at that point. So how would they do it? So a couple themes coming up, definitely from my experience and just from where the literature is pointing to us. So the idea of planning. So this whole reorientation of population health management in our health system is making us think about being a bit more proactive versus reactive. It's not just what happens when the patient comes through the door or when the problem lands on your doorstep. We have to be prepared. And this makes us think about being proactive, about using lots of mechanisms to be proactive, including not only, but the idea of using data and predictive modeling as one aspect of it, but equally as important, engagement. All of you and many of you I know have done very impressive community engagement-led work. You know that those relationships don't just start overnight. They need to be fostered, nurtured. There needs to be relationships, trust building. That does not happen, right in the context of emergency. It does not happen even in a couple months. This is a multi-year process that's paired with addressing some of the structural issues that we know that many communities face. So that planning and proactive orientation really is about starting to think about how we can put some of these mechanisms in place earlier. The awareness piece is obviously something I think a lot about. And I have a question here. Do the data systems transparently allow for real-time situational awareness? No, I actually don't think there's any robust real-time surveillance system that relates to public health and health systems. There's some examples of very specific ones around the world, and there's some great collaborations and efforts, especially in the area of infectious diseases and disaster management. But really, we don't just need to know what's coming, we need to know who's affected, and much more quick information in real time. We need to have the ability to be able to absorb that information. That means having people that have the time and space to be able to take that information and respond very quickly. Flexibility as a key concept of resilience is something that, again, as I mentioned at the beginning, we have a long ways to go. And thinking about how we measure resilience in our health systems, if something is too rigid, it will break. We need to have some give in the system. I think when a system is just so strained, like our health system, it's really hard to have that give in the system. How do we build it and how do we measure it? If we measure it and we indicate, if we state that a key performance management indicator is one that has flexibility in the system to be able to adapt, then we will figure out some mechanisms to make sure it is in place, and we will state that we actually value this concept. And of course, resources, which I know is an easy answer to all problems, but simply put, we cannot expect to be prepared if we don't invest in preparedness and see the value of it. I think COVID has definitely shown us this, but lots of other natural disasters and threats to our system have showed us this before, how important it is to be prepared and to invest in it on purpose. And lastly, I've kind of harped on this from the beginning, but it's not just the indicators or the measures themselves, but it's how they vary across the populations. Those ideas of trends and relative positions and who we're leaving behind is something that I think is not present enough just in performance management in general, but in particular, it's critical for resilience framing in performance management. So I'll end with just some things that keep me up at night. I want to show my enthusiasm for the idea that resilience should be considered in the concept of performance management, but I'm concerned about many things, including the unintended consequences of how these measures will be used. Will they be used to take high-performing areas and invest more money in them and create an inequity issue, for example? So there needs to be very careful thought there. There are unintended consequences. Who's setting the standard as to what's good and bad? It's really challenging in the context of an emergency because we don't have a lot of experience, and every single emergency or threat is different. The response is different, the implications are different. And so setting the standards can be quite a challenge. And I mentioned already the inequities that tie in with how performance will be used. So I will end with just some final points in that I hope that you see that performance management is widely used in health systems, but the incorporation of resilient concepts are not. There's a lot of work to be done in this area. If you're interested in the area, I think this is a really rich and growing area to focus your energy. As always, hopefully we know over time that the interdependence of public health and healthcare systems are critical. Resilience, I think, is a concept that shows it more than almost any other concept in health. We have lots of challenges with data inputs. They're currently far too narrow. They don't come quickly enough, and they have to evolve to embrace the complexity. But luckily, there is a lot of work in this area, but again, a lot of work to do. And clarifying who's accountable and responsible for these measures. So I want to just acknowledge my lab and funders and all the great people I get to work with, and happy to take a few minutes of questions. And I'm going to stop so I can see people.
Great, thank you, Laura. Excellent as always. So we have about 6 minutes for questions, so I'll open it up to anyone who might want to go first. Tracy.
Thank you, Laura. I've been so excited in anticipation of this talk, and boy, you sure didn't let us down. It exceeded my expectations. I'm so interested in this work. Thank you very much. One of the areas I find fascinating because I work in low resource communities is in the idea of developing a system that can accommodate the vast range of inequities that you describe, right? So in terms of just basic preparedness within the system, as you know, there are communities within Canada, some of them within larger metropolitan settings, and then some of them that exist at great geographic remoteness. And they don't have resident physicians, or they lack basic infrastructure and services that to the rest of us define the minimum standard of care. And for those communities, we have had an experience of performance management that's a few decades old in the standards of care. Right? So I remember being at a group of clinicians presenting some work on cancer services for residents of Nunavut. And one of the clinicians asked me after my talk, what was the rate at which, a certain standard of care was met for people living in Nunavut? And of course it's zero. Right? Like, people living in Nunavut don't even expect to meet standard of care. So how do you think about accommodating that range of experience when you're doing this work?
Thank you, Tracy, for your comments, and it's such a great point. And I think with COVID, this has come up actually quite a bit. I mean, it's just simply, so it's unacceptable, right? That it's zero. And so, and if we think about a very basic indicator, like how many, every home or residence has running water. And we have, places in this country where that's not true. And so for me, the answer to that question is less about, incorporating it in there, although you can incorporate it in there by saying, well, if there are places with zero, that's unacceptable. Like, we are not allowed to proceed as a system until we fix this problem. But also it's the accountability piece. And I think because of the fracturing of our systems, it's not whatever the hospital's problem, right? Or that particular regional health authority, or that it's that problem up there. And I think that that's been a huge failure in the way that performance management has been implemented. So it's fallen down on accountability. In California, which was really interesting, they implemented, a community vulnerability index to COVID, and they're essentially saying, we have our color-coded systems now, right? You don't get out of the color-coded system of lockdown until the communities that are most vulnerable are doing just as well as those that are least vulnerable or least socioeconomically deprived. So imagine we operationalize it that way. I think that would be a huge difference.
That is really interesting. I hadn't read that. Michael, can I ask a follow-up question?
Yes.
Okay, it's not a follow-up question. It's an unrelated question, I should declare. Within, so that was a question really about the primary healthcare system.
Right.
When I'm thinking about public health, one of the things as an Indigenous health researcher, I'm always interested in is the legacy of public health in terms of its emphasis on behavior and education. And I wonder if there's a way to operationalize performance management for public health that lets us step away from evaluating the system performance based on individuals' behavior or the success of, these educational campaigns. I mean, there's always this assumption that people just don't know enough about what diets will be healthy, and we need to provide more educational resources, right? So
Right.
I jotted down some examples, like and they crop up for us. We all use them really easily, but instead of evaluating whether people are eating fruits and vegetables, we could be evaluating their diabetes prevalence or their cardiovascular disease incidence, or whether there's harvested food available in the store, right? Instead of breastfeeding rates, we could be monitoring infant growth, right? Could we get away from those sort of behavioral focused measures and move toward the structural as a way to assess the quality of the system?
Absolutely. I mean, that's my dream. And I think there is a bit of a shift. I was doing some work in Ontario with the revision of the public health standards, and there was much more of an emphasis on the structural process factors. I think people know actually that's where we need to go. So I don't think there's resistance in the system to do it. I think people don't know how to do it. They don't know how to measure it, and they don't know how to operationalize it. And that's where I think, like, even us as an academic community, we can add a lot of value. It's why I'm so excited about that project that I mentioned, because I think everyone knows what we have to do. We need to stop measuring the things we're measuring and actually start measuring some of these factors. We need to get the data on it. We need to understand it. We need to make sure it's conceptually sound. And I think that's where we're moving. I'm optimistic, but I do think there needs to be more work on our part as academics to be able to make it easy for implementation and actually provide that sound basis so that people can take that indicator, they know what it means, they know how it works, and we can actually start moving the needle on the things that matter. I always tell people, it's like, remember the old stereos where you had like the big dials and the small dials? We've done enough of the small dials. We need to work on the big dials. And even just a little bit of that big dial will have a big difference. And so I hope that's where we're moving. That's certainly where we're trying to push with our measurement work.
Great. Thank you, Tracy. Thank you, Laura. We have a question from the chat. I know we're after 5, so if anyone has to go, please, of course, feel free to leave. But I just want to make sure we have an opportunity to get to this question, which is from Sarah.
Yeah. So this
Sarah,
is, yeah.
Oh,
go ahead.
Do you want me to read it, or Sarah? Do you
Yeah,
want to
someone
read it?
probably should read it.
Okay, I'll read it unless you want to chime in, Sarah. So Sarah's wondering about your thoughts on whether social capital and its measurement may help inform some aspects of resilience, and are these measures in place in any public health performance framework that you're aware of?
Right. And thanks, Sarah. And Sarah's a performance management health system expert, in case you don't, others may not know. If I had to pick one measure that we could implement actually relatively quickly tomorrow, that this is what it would be, is something around community belonging and social connectedness of community, because it's only one aspect. Community engagement would probably be another one. That is the community's voice, how much a community's voice is actually in the decisions that are made. But those are probably the two most critical aspects to resilience. Now, do they exist in any frameworks? No, they do exist a little bit in, I flashed up that flourishing framework from Vanderweel that's really talking about how do you measure healthy communities that flourish. So there's this kind of movement to measure flourishing communities and human flourishing, and that's where it exists, but it hasn't been necessarily framed as critical for resilience. So I haven't yet seen it there, but hopefully as we start thinking about measuring well-being, community flourishing, it'll start showing it more. It's not hard, actually. This is one where we could implement. There are very straightforward questions you can ask people about their involvement in community. We just have to talk to people and not just measure when they come in and out of things and have things done to them. It's actually pretty easy to ask people and get a handle on this one.
Great. Thank you, Sarah. Thank you, Laura. Any other final quick questions? Maybe we can do one more fast one if there's anything else. Okay, last chance. All right, well, we'll call it for today. Thanks to everyone who came to our last talk this semester, and we look forward to seeing everyone next term. We've got a nice lineup of speakers starting, I believe, in January. Is that correct, Chris?
Yeah, January 11th is our first one.
Okay, great. So January 11th. And again, a huge thank you to Laura for a fascinating talk. We really appreciate you taking the time.
Thank you all for coming on this last week and for the really great questions.
All right.
Happy holidays, everybody. I hope you get a bit of rest.
Yes, and you too, Laura. Happy holidays and have a good rest of your week, everyone.
Bye.
Bye.